And the next lecture in this session will be given by Dr. Matthias Miederer, Deputy Director at the Department of Nuclear Medicine at the University Medical Center in Mainz. And he will be talking about the use of imaging and biomarkers to predict the efficacy of cancer immunotherapy. Matthias, please.
Dear ladies and gentlemen, dear Chairman, thanks a lot for the introduction. I'm very honored to speak here in this impressive conference, and I already learned a lot. I'm a nuclear medicine physician, and in nuclear medicine we are using radioactive probes that participate in certain metabolic pathways, and we apply this for diagnostic when this accumulation of radioactivity can be detected by positron emission tomography or by the older technology of SPECT imaging. And in this talk I will focus on two very important pathways that are used for in immunology. One is the glucose metabolism, which is an important basic pathways that is known for a very broad number of indications, and we use the glucose metabolism by FDG PET on a day-to-day routine, mainly in oncology. But with changing the instrument from a large from a clinical PET to a small animal image, you can also use this in preclinical work, and you can study more effectively the correlation with metabolic pathways, and you can also manipulate the mice and understand what the signal means, and you can use also the signal for giving some information or some output marker. However, the basic immunology is always important to in the end change the T cells and try to induce accumulation of T cells. So this is the other part of the talk that is centered a little bit more on the T cells. Here it is not that easy because T cell imaging is not something we can derive from day-to-day routine. However, the T cell imaging is probably the main imaging for the future. We have characterized in a graft versus host model, and I will give very briefly some outlook application, which in this conference have been already discussed extensively. I will start with a clinical imaging we are seeing in daily routine. This is a patient that is presented for imaging, for initial staging, for operation planning, and the question is, what is the extent of the disease? And due to the high glucose uptake and the energy consumption of the tumor, the PET imaging is very sensitive to give the extent of the disease and to guide therapy, in this case surgery. However, this is another patient also with a pulmonary disease, and he was referred for also for imaging with a suspicion of malignancy. However, this imaging looks fairly similar to this malignant one, but turned out to be an active tuberculosis. And this is actually what we do see as false positives in routine, which refers to the immune system. With malignant cells, the change of glucose metabolism and the increase of glucose metabolism is very well known for several decades, and this is a shift of oxidative phosphorylation to an aerobic glycolysis, which is associated with malignant growth and is very well understood. However, immune cells are increasingly known to use same pathways where they shift the metabolism from an oxidative oxidative status to the glycolysis, which probably means something. For example, in dendritic cells, there is known a direct link from toll-like receptors to the hexokinases, which is the key enzyme determining in the end the PET signal. By changing to the glycolysis, here there is probably releasing compounds from the citric acid cities, which is then used to increase the fatty acid synthesis, which is probably the basis for the function of the immune cells, where the endoplasmic reticulum is increased, the proliferation is increased, the membrane surface is increased. Therefore, this change in glucose metabolism we are seeing in FDG PET has a fundamental biology. And if you look at mice, when we stimulated toll-like receptors, here you see toll-like receptor 4 stimulation by LPS. You can see the signal where it is expected. In the spleen, we see a slightly increase of glucose metabolism after toll-like receptor stimulation. Also, we see it in another cascade of this toll-like receptor 9 stimulation by a CpG stimulation, also very similar. And if we analyze what we are seeing, we see what we expected from theory that the FDG signal is extremely rapidly increased. So this is the first switch we can easily take up by imaging, where the cells are activated and then go on with their repetitive function. It's even significantly earlier than the classical activation marker we see on FACS analysis. However, depicting unspecific toll-like receptor simulation has got not a very fundamental application. We have got a great growing group who are establishing vaccination and for tumor therapy. The group of Ugur Sahin and the affiliated company BioNTech has developed systemic vaccination therapy by targeting the spleen by modification of the lipoplex structure that carries mRNA directly to the spleen and then is translated and directly can work to generate within the spleen tumor killing lymphocytes. Again, we see in FDG PET, if we screen for the mice after vaccination, that there is also, like in toll-like receptor simulation, here is the activity of the spleen increased to a high extent, although in control with the empty peptide, there is nothing happening. So this is not an effect of the macrophages, this is the effect of the immune systems. And here this is the ex vivo quantification. And again, if you look at the time scale, this is what is happening. After 1 day, the activation in the spleen is active, and after 3 days, it is gone already. So what we are not seeing is the proliferation of the T cells. We're actually seeing the so-called self-adjuvant properties of the mRNA, which is also toll-like receptor dependent, and the T cell proliferation comes later when the activation of the immune system is not that evident anymore. We had the chance to also screen a patient in a parallel ongoing clinical trial, which is a phase 1 clinical melanoma trial, working with the same systemic vaccination. And here again, also in the human situation, you see a patient that was vaccinated, a baseline. You see the spleen uptake. This is the normal distribution of the FDG within the human. And only a couple of hours after one of the vaccination cycles, you see this increase, this tremendous increase of spleen metabolism due to this activation. So, however, what this really means is another question, and the application for this is a very challenging question. What is the meaning of such an activation for the outgrowing lymphocytes? And we are able to localize the site of activation. It is, as expected, the spleen. It's not the bone marrow, or it's not the liver. We can quantify it, how much it is, but we cannot say, is it absolutely necessary for proliferating lymphocytes, or how is it correlated with therapeutic effect? Then I will move on to a even more challenging imaging strategy, where you want to image the tumor-infiltrating lymphocytes. Also here with radioactive labeling, the zirconium 89 labeling has already been mentioned. There are papers already out that are able to visualize the tumor-infiltrating lymphocytes within the tumor, which is very promising and deserves translation into clinical. We also applied radioactive labeling of monoclonal antibody, which is binding to CD3, to image the immune system. In this case, we evaluated the system in a graft versus host disease, where we inject the tumor cell, the PBMCs into mice, and image then the distribution of the radiolabeled anti-CD3 antibody by PET and ex vivo biodistribution. This is what we see. You see here the normal distribution of the CD3 antibody. Here, a very prominent signal within the spleen, which is the normal metabolism for monoclonal antibodies. And you see here, with this graft versus host disease in the typical spots like the liver, also a little bit in the gut, the increase of T cells. When we compare it to the quantification we derive from measuring the organs after dissection, we could not see any big differences, which is to be explained that the size of the T cell accumulation is rather small. Here, this is one of the CD3 staining of most of the liver, and you see here the small clusters of T cells that are easily visualized as spot-like lesions within the PET at a high resolution. Therefore, this imaging is feasible, and we can, in a small animal scenario, detect T cells, and we can follow them. And this is one of the slides that has been extensively discussed, this principle that if you see T cells within the tumors, this is a prognostic factor, and we more or less know for sure that if you can cause T cells to infiltrate the tumors, this will have got a dramatic effect on therapy. Therefore, I would like to conclude that FDG PET is a very available method that can be applied to image activation of the immune systems and might help to understand mechanisms and the individual patients. And it is also very feasible to image T cell expansion and migration of T cells. And I would like to advocate that a companion imaging diagnosis should be co-developed with therapeutic interventions to clearly understand the mechanisms and also to individualize the resulting therapies. Thank you very much.
Thank you, Matthias. Very nice talk. So when will we have anti-CD3 labeled, radio-labeled, and anti-CD8 radio-labeled agents for imaging the immunogram of the cancer, just like Jerome earlier said?
This is, unfortunately, we have realized a change in regulatory burden, and it is this very promising and not that complicated strategy means, translated, this is development of a new pharmaceutical, as a new drug with all the regulation. So it will be very cumbersome to overcome and to have this drug approved for human situation. There are some countries where it is easier. We in Germany have the possibility to use something on an individual basis, but it is difficult to apply it for structured clinical research.
But it's definitely something that we need, I believe. There are questions. Please go ahead.
If I interpreted your message correctly, you had to wait 48 hours before you take the image with the antibodies in mice. Was that correct?
No.
You showed image 48 hours after
I could have showed imaging 24 hours or 48 or 72 hours, so there is nothing happening really. So it's the antibody is accumulated relatively fastly. It is diffusing or it's accumulating within this liver, and there are no big difference. So the 48 hours there, I had nicest pictures. That's the only reason.
My point is just that that is quite a long time, and it's in mice. How long do you then think you need to wait before imaging a human?
For a monoclonal antibody, I would wait at least a couple of hours. I think 4 hours or even 24 hours might be the ideal time point.
I would be interested, how do you explain the high selectivity of the immune activation to the spleen? Yeah? And if I would remove the spleen, how would then be the immune activation?
So we looked at the different cells, and it is mainly the B cells and the dendritic cells that are really activated. It's not the macrophages and the T cells that are later express the target are also a little bit activated. And the vaccine is directly going to the spleen. So there is the organ where everything is happening. If the spleen is not there, I'm not sure what is happening. Then it's probably spread all over the body, a little bit in the lungs, in the liver, or in the bone marrow.
It's a delivery issue.
I think so.
Very interesting talk. I do have much more technical question. When do you prefer PET CT? When do you use PET MRI?
In clinical routine, we have got PET CT scanners. CT is much faster, and it's probably the method of choice for all clinical questions, at least in oncology. For the mice, the MRI was really helpful to exactly delineate the spleen from the adjacent gastric wall, and therefore I was very happy that we have a PET MRI in preclinical setting. For the clinical routine, I do not think it's very important.
Time for one last question. If not, then let's thank Dr. Miederer again.